Well, good afternoon. So welcome to our October meeting of the Public Health Advisory Board. Welcome to everyone we have here in the room. I think we have a few members by phone. And so we've got a few items on the agenda today. We're going to talk about the leadership of FAB in the after this year. We're going to hear and make some input about tobacco prevention funding, of which there's less in this plan, unfortunately. We'll vote on public health process measures, which is a follow-on to the accountability measures we adopted before, and then we'll hear about the action plan for health. So that's our plan today. We plan to be ready, finished by 5. So anyway, just to kick things off, let's introduce ourselves. My name is Jeff Luck, Oregon State University Chair, and how about we just go around and ask everyone to introduce themselves.
Hi, good afternoon. I'm Elaine Shirley, the Public Health Director at the State Health Department.
Hi, I'm Carrie Bergiotti. I am the Public Health Administrator at the Center for Human Development in Union County, representing CLOVE.
Katrina Hedberg, State Health Officer with the Public Health Division.
Good afternoon, Alejandro Queral, United Way of the Columbia Willamette, member at large.
Rebecca Pavlik with the Hospital Association, representing healthcare that's not a coordinated care organization.
Bob Dan Hubbard, Public Health Officer from Douglas County.
Egoripto Apsby, representing public health workers. Is that right? I can't remember why. Why am I here?
Hi, I'm Muriel Taylor Burton-Brown, and I'm Director of Health and Human Services for Kirk County, representing small counties.
Great. And do we have any members of the board on the phone?
Hi, this is Carrie Hollifer with North Central Public Health District, serving Kelly, Trimble, Washington counties, and I represent the Frontier counties.
This is Eli Schwartz from OHSU Community Dentistry. I think I'm a specialist of some sort.
Metrics, Ely, metrics.
Is Kelly on?
Yeah, this is Kelly Little, Health and Human Services Administrator for the Kokolo Indian Tribe in Coos Bay, Oregon. Here.
Welcome.
Thank you.
Great. So thank you. I think we have a good turnout this afternoon. Let's take advantage of that and review our minutes. We actually have 2 sets of minutes, right, Kara? We have in your package, you will see both the June minutes and the September minutes, because at the meeting where we would have approved the June when we didn't have a quorum. So do we approve them separately? Does that take 2 motions to approve them, or if we do it in one? Oh, okay. Well, if anybody would like to make a motion about approving the minutes. Yeah, great. Thank you.
Maybe late, but
Your timing is just right. Is that both the June and the September?
we're getting a little punchy.
No, so Dr. Banksburg just arrived and moved to approve the minutes. A second?
Second.
Thank you. So any suggested changes or additions to the minutes that are included in our packet? Give everybody a minute to look at them. any suggested changes or additions? Okay, well, I guess I'll ask for a vote. All those in favor of approving the minutes, please say aye.
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 Thanks. Any opposed? Okay, great, thanks. That's taken care of. Actually, while we're talking about minutes, I'd like maybe just to say something about our staff. Our minutes have been compiled for the last couple of years in this group by Angela Rowland, who's also just kept us on schedule and organized and things like that. So Angela actually has a well-deserved promotion within Public Health Division and is going to be moving on to another position. So congratulations. So Angela's here today, and Julia Higgs is going to be taking over her responsibilities. So you can all say hi to Julia over the course, and welcome. And thanks again, Angela. Good luck. The other good news we have today is 2 new board members joining us. Actually, 2 new board members from Southwest Oregon, which is an excellent, excellent increase in our regional diversity. So, Dr. Bob Dannenhofer from Douglas County, and Kelly is representing tribal public health agencies, and that position was just added to the board by the legislature in the current biennium. So welcome to you both. And there are opportunities to serve on subcommittees. That'll be discussed during the meeting. So if there's one that interests you in particular, please let us know. There's another position of our board that has become vacant. Tricia Tillman is no longer in her position at Multnomah County, and so Tricia is not going to be on our board. I will miss Tricia a lot, having run the board. So I really, really appreciated her, advocacy for public health and for health equity and just, many other issues. So, I want to thank her for her service on this board. One of her large county colleagues has submitted paperwork to the governor's office to join us, and I think that group of counties is going to be very well represented by our prospective colleagues. And hopefully by next month, that slot will be filled again. So I think that's, Kara, I think that's all the personnel updates, right?
Yeah.
Okay. So one other thing we wanted to give an update about is that there have been community meetings about the state health assessment over the last few weeks. In LeGrand, in Portland, Eugene, Grants Pass, Medford, Newport. Wow, that's covered a lot of ground there. As well as a meeting in conjunction with the OHA Tribal Representatives meeting. And so there's one more to come next week, but Kara, Katrina, could you maybe give us just a brief update on that? Those meetings?
Yeah, so thank you. As you said, Jeff, we've been having these community meetings around the state. And this is only one aspect of getting input from the community. So we're having these meetings, and a number of the folks who are on the steering committee for the state health assessment are coming to those, and we really are trying to get outreach to community members. We're also encouraging folks to complete, who haven't been able to attend one of those meetings, to complete an online survey. And what's really been interesting, so it's the The participation has varied a little bit in several places. I was just in the one in Newport, and Karen and I are going to the one in Madras in a week. And I know others have had sort of strong participation, somewhere between 25 and 30 people who felt very strongly about giving their opinion, so that's been wonderful. There have been a couple of places which have had less robust participation, and I can let the staff talk to those. And I'm not sure that means that the community isn't interested or engaged. We just need to do a really good job of doing that kind of outreach and assuring folks that even if they haven't been in person at one of these community meetings, we're still looking for their input. So again, this is really the assessment part of it, not the action. So at least in the one in Newport, I could tell folks were chomping at the bit to move on to, so what are we going to do about the problem? And we had to say, well, we're still in the assessment stage. We're in the current stage of the State Health Improvement Plan, but this current assessment will lead into that. And it was interesting because a lot of people, I do think, and this has been true for other settings, really are focused on broader issues around social determinants, what in general the community can do, as opposed to some of the very kind of specific or concrete things that we might be measuring. So, Kara, I don't know if you have more to add on that?
You did a great job.
So,
Happy to answer any questions.
was there anything else that sort of struck you that you either hadn't expected to hear or that really validated something you had expected?
No, I think, in general, so the couple of categories, sort of that people who come, are clearly people who understand sort of what public health does or what community health is, et cetera. There are people, I think, who come to all of these who see that this is an OHA, health assessment or listening session, and are very interested in what we're going to do about universal health care, for example, or, that there. And so we have to say, well, that is part of what we do is healthcare access, specifically around clinical preventive services, but this is really broader around health status. So I think that continues to be, and probably in not just people at these communities, but in a lot of folks' mind when they hear health or even public health, they're thinking about health care as opposed to more of the upstream health thing. So again, I think that's a little bit of a challenge, but that certainly fits in the bucket of things that we're trying to assess.
Great. Any
Just
other?
add
Oh,
something
sure.
about this. So sorry. So I think you all received an email last week with a link to a couple of the documents that you have as a part of your handouts. But these are some case studies that the Public Health Division has been working on over the last couple of months. So they're titled Improving Community Health Through Cross-Sector Partnerships. We did just print out the two examples that relate to two of our FAB members who participated in this process, but there are several others available online. Again, this is just designed to showcase some of the work as a part of our statewide public health modernization plan to be working across sectors together towards health. Happy to answer any questions.
Good, thank you. Nice. Okay, and I think we actually had a couple of other members join us. So, Kiko, Jennifer, thank you. So, we have everybody here today.
Except for Sabina. I think she'll
Oh, yes.
Otherwise, we're at 100%.
Well, Sabina's like in that sort of any day sort of mode, right?
Jeff, I had a comment to the comment from Kara a moment ago, if you don't mind.
Oh, yeah, please go ahead.
This is Ely. I just wanted to say that this work that Kara and Sarah and others have been doing in terms of actually producing these examples of case studies is, to my mind, is absolutely brilliant. I mean, I don't think we could have found a better way to actually have examples to present to people. I actually used one of them yesterday at the World Health Conference, just to show people some concrete examples, because oftentimes they'll come and say, well, how does this work in practice? Or, well, this is probably not really relevant for us, or something like that. And then to actually be able to show a very concrete and well laid out example that these productions actually represent, I think is very, very helpful for the work that we are doing when we try to promote these inspiration activities.
Thank you, Ely.
Yeah, thanks. I mean, these are really well done, so thanks.
And I'm glad they're useful already.
Okay, so the next item on our agenda is to talk about our membership and leadership. So I think, let's see, so we talked about the new positions. And we have 2 other positions on the board that are expiring at the end of the year. And Eva is, we're very glad, is going to be applying for readmission. Safina is going to be busy with a much larger family literally any day now. And so she's, she won't be reapplying, but we're hoping that another CCO representative will be able to join us by January. So, Carrie, you're going through the regular process of soliciting candidates for that position.
Yeah, but we wanted to have the conversation today, and then we'll be getting communication out about that vacancy.
Right. So, I mean, if any board members know of any, potential CCO representatives who'd be interested in, serving as a member of the board, please get the word out and ask them to get in touch with Karen. And then the other leadership item is that the board chair and co-chair terms are for 2 years. And so this, as of the end of December, it'll be 2 years that I've been chair and Carrie has been co-chair. And so I'm looking forward to being able to hand over the reins to another member of the board as chair. So what we thought, well, Carol, what would you say about the process for that? We talked about that briefly.
Yeah, so I think we wanted to take the time today and introduce that this will be coming up, and in the meantime, if anybody is interested, they can let me know, and we can keep a list to bring to our next meeting.
So just a question about process. Like Eva, offering to re-up her term, is it possible for chairs to re-up, or does that, I just don't know what the rules are.
I think that's possible, but I'm committing to another couple of years is something I'm not quite able to do right now. I have said that if there's like a, if we want to make some sort of a transition, I'm glad to help out in whatever kind of capacity is there. And Carrie's also expressed interest in continuing on as part of the, well, or not, or is that still?
Right, so my question, thank you, Jeff, my question was really just about what's allowed and what isn't allowed. Certainly we have very much appreciated you in your role, but it does take energy, and so we do understand that people might want to be, turning over, passing the baton, as you said. Just wondering about what's allowed.
I think it's actually very flexible. So I think anything, if any members are interested in doing it, I'd be happy to talk about any sort of configurations for that. And then, also just to talk about, what, if anybody's interested in knowing what the chair, what the responsibilities entail. I mean, the staff is excellent. So Kara and her team make the doing the job really very feasible. So I think if there's any other questions, I mean, I hope some of you all are interested in doing that. I know there's actually several good options among this group. So I feel really confident that we'll have good leadership going forward. Okay. Then we also at some point need to update probably the bylaws to be a little more concrete about the length of the chair position. But
Yes, so I mentioned at last month when we adopted the new format of our charter, that there's been a lot of work across OHA to standardize the support provided to the health policy board committees. So the standard charter was the kind of first step in that process. Another piece that we haven't had a chance to quite formalize yet is on bylaws. So I will anticipate getting a template that we're supposed to be using for all of the health policy board committees related to bylaws. And so this will be an opportunity for us to go back to those specific aspects on how we operate as a board and come to some decisions on all of that.
Okay, great, thanks. So let's over the next couple meetings, we'll make our, we'll formally act on these items.
And I just have one other addition. I know Jeff mentioned for our new members, we have 2 subcommittees. Actually, staff have had a chance to talk to both Kelly and Bob about what those subcommittees do and getting some interest from them. I think once we get into the new year and we have some new appointees, we'll want to revisit our membership on both of those subcommittees and make sure that we have kind of an even mix of members. We've had some significant change in our incentives and funding subcommittee, and although they're on hold until we get to 2018, there's going to be quite a bit of work to do next year related to the local public health authority funding formula. So it'd be good to take a look at the size of those 2 subcommittees, who's involved in them, and then see where we might want to make some other additions or changes.
Right, and those, I mean, I was just looking back at the minutes, I was impressed by how much work those, I mean, how much has happened in those subcommittees. We're going to hear about it, you hear about one, and, well, actually, the next 2 items are talking about things that have been discussed in the subcommittee. So encourage any members who have the time to join those discussions as well, because we actually got a lot more chance to go into, or the chance to go into a lot more detail about particular issues. Again, the staff can bring information to that committee meeting that we can really dig into more deeply so that we can come to this board with some more focused recommendations. And speaking of that, the next item on the agenda is something that we talked about in the most recent incentives and subcommittee meeting, which is funding for tobacco prevention in the state. Unfortunately, the budget passed by the legislature has a significant reduction in tobacco control funding. There was what's called a budget note that requires the health authority to consult with FAB on recommendations for how to absorb that cut. So we have so is Karen going to let us know what the latest is there? Just as background, this was the main topic of our incentives and most recent incentives and funding subcommittee discussion. There's a handout which is on the screen right now, which is something that the staff put together, which I think is a good one-page summary of a lot more detailed budget information that talks about what the top row tells us what the previous biennium budget was. The bottom row with more details tells us about the 27-19 budget. So Karen, if you'll sort of walk us through that, please, then we can have some discussion about it.
Thank you. As was said, unfortunately, the Tobacco Prevention and Education Program for the current biennium, the budget was cut about 20% by the legislature. So we went from almost a $20 million biennium program to about $16.3 million. So those are some significant cuts that we've had to absorb across the program. And we've talked here before about, luckily in tobacco prevention, we do have a lot of evidence about what works for preventing and reducing tobacco use. And we use the Centers for Disease Control and Prevention's best practices for state tobacco control programs as a guide to help us make sure that we have the right mix of approaches to reducing tobacco use. As with everything, there is no single intervention that's the secret that's going to do it. It really takes approaching tobacco prevention from all different sectors, and cumulatively that works to help prevent youth from starting to use tobacco and to help tobacco users quit. And using the CDC best practices, and depending on where a state is in the funding, in what they recommend for funding, we use the best practices to allocate our budget. The CDC recommends that Oregon fund tobacco prevention and education at $39.3 million a year. So we are quite a bit below what the CDC recommends for Oregon, at being about $8 million a year. Given where we are, so that's called the limited reach, meaning that we're going to be able to have limited reach with those kinds of funds. The CDC recommends, you'll see the percentages here in the recommended budget target for the different components of a comprehensive tobacco prevention program. This is what the CDC recommends given Oregon's funding situation. As funding increases, those percentages might change. For example, if Oregon were at full funding, the CDC would recommend a lot more money going into cessation services directly, and less money going into community programs, for example. But given where we are, this is what the CDC recommends, and we really try hard to meet those targets. What we have worked through with the Tobacco Reduction Advisory Committee and CLO, this is the recommended allocation that we've come up with is the actual budget target. The next line down, showing that we're close, but we are above CDC recommendations for state and community interventions and below for cessation, for example. And then the bottom row shows the change in what will change with our programming given this budget cut. And tobacco prevention is really a dose-response relationship. The more states and communities spend in tobacco prevention, the more success that they do see. So unfortunately, we anticipate seeing less success over the next 2 years. But we will try our hardest to use those resources as best we can and as effectively as we can. The biggest change in how the program is structured is with the community programs. And community programs in our budget are funding that goes to local public health authorities, but also funds that go to tribes and regional health equity coalitions. Both the funding to local public health authorities and to the tribes were essentially held harmless in this budget reduction. The counties received a 1.5% decrease and the tribes were held even. To hold those programs harmless, we took a big hit in what we are able to do for statewide interventions and statewide policy successes. So you'll see that there's 53% decrease in statewide interventions, and so those are the funds that help support those community programs through training and technical assistance and things like that. So that is the biggest difference in this budget. In working with CLO on what funding will go to local public health authorities, we've agreed to form a couple of work groups to look at what accountability measures we'll be agreeing to for the funding that counties receive over the next 2 years, as well as revisiting and looking at how the funding formula is for local public health authorities. Right now there is a formula that provides a base depending on the size of the county, and then the rest of the funding is distributed using a per capita distribution. That may not be the best way to ensure that that quality tobacco prevention work is is being done across the state, and it also does not, may not be flexible enough to allow for how we can use those local community programs to help contribute and roll up into statewide successes. So we will be working with CLO over the next 18 months to talk about those very difficult issues, and certainly, you know, maybe there will be more funding in the future where we've had these discussions and know what we would want to do with this funding, and hopefully there's more money to talk about rather than less. Any questions?
Yeah, go ahead.
Thanks. I'm just curious how 1.5% decrease is holding the local public health authorities harmless. I wrote down, what's the real impact of that, especially for staffing and especially for areas that are already struggling to keep staff?
Right. Well, it's not harmless. I mean, it is a decrease, of course. It's, but it's the lowest decrease.
Yeah, I mean, yeah, it's pretty small, but we have one county that's now striking and potentially others, and so, in that is public health. So it's really hitting home for me that these amounts mean a lot to the people on the front lines. And I know I've said it before that, you know, that there is no more doing more with less, and now we're really seeing it.
Can I just clarify? The tribes were held harmless.
Oh,
I just might have misunderstood that. Thank you.
What, and so Karen, what, in the statewide interventions that they're reduced, am I correct in remembering that the Search and Spark are the program, are a big chunk of that reduced funding?
Right, yeah, the Search and the Spark grants were policy and systems change, competitive funds that were available to communities that were very successful in achieving policy change. Those were what were eliminated in order to minimize the cuts to local public health and to hopefully we'll be able to use what we've learned from those programs and implement them as much as possible in the LPHA funding, but that is the statewide intervention that was cut.
Yeah, those are the ones we heard about, that this board heard about last month.
Right, and also the training and technical assistance that is available to local public health authorities and regional health equity coalitions and tribes has also been cut.
Okay. Mira, go ahead.
So one of the things I would say is, I do appreciate that we were able to come to some kind of agreement on this. I think the thing that it really teaches me is the Spark and Search grants were new dollars. And it really, I mean, even at the local level, we're doing some work with our CCO around tobacco. And I think thinking about this differently, like how do we really leverage the Medicaid dollars, the CCOs, this is many of their clients. And so how do we also look at that? I think the dollars that are coming to the locals are sort of the same dollars that have been coming to the locals for quite a while. So the Search and Spark, and we were one that had a Spark grant, and it was great. But my coordinators, you know her, she does a ton of work, and she's done it for 20 years. So, but I think we need to look at how do we do different strategies around engaging the whole system to look at this tobacco issue, and maybe do that together. And it might be, it just feels like that's sort of the direction as your committee gets together to think about too.
Yeah, Rebecca and then Dan.
Yeah, two thoughts. One, similar to yours. I know we didn't talk about the cessation section, but this increased focus on partnership, I'd be curious in those two work groups to have a conversation about how much money has been leveraged and what that looks like and quantify that in an accountability or a funding formula conversation. My second comment is those two work groups sound very similar to the two work groups that we have here on the FAB, and so I was wondering if the idea was these would be part of our FAB work plan, like subcommittees of the FAB, or is this totally just OHA and CLO separate, or is there a role for the Public Health Advisory Board?
speak to the comment about system-wide approaches to covering some of these deficits and maybe even going forward. I think 2 meetings ago, we had a discussion about, when we were talking about metrics and what is the role of the Public Health Advisory Board in informing metrics, and I brought that to the Oregon Health Policy Board. And I think there was a plan in place for metrics to come and talk with us, and it was a productive discussion. We have that communication going now. But that stimulated a conversation around CCO negotiation, contract negotiation. As many of you probably know, the contract negotiation has been delayed a year. And one of the reasons, there's probably many reasons to do that, but one of the reasons is to have a discussion around how we can design those contracts or structure those contracts for more upstream impact on health, and also moving from just healthcare in the clinic, covered lives, to healthcare in the population. And I think that was very well received. And there's a lot of interest on the whole Health Policy Board to play a role. And we got a letter from the governor that really endorsed that mission. So I think there was questions as to what kind of state and local support there is. So I think there's a real role for this committee here as we deal with challenges like that. Is how can they be moved to CCO level, and how can that inform contract negotiation for the next round of the CCO contracts?
So David, what is the timeline for those negotiations?
They were, I don't know they were supposed to happen start very soon and happen this spring. Is that right, Lily?
Correct.
Yeah. So they've been delayed 1 year. So they will begin discussions a year from now, or contract negotiations a year from now. So there's a 1 year for us to plan, or discuss and plan and make recommendations as to what should be the important public health components of those contracts.
Staff, this is Terry.
Oh, yeah, go ahead, Jeremy.
Hey, I like that idea of looking at the CCO contracts. My concern is that unless the contracts require the CCOs to engage with the governmental public health system to do that upstream public health work, we've already seen CCOs create their own systems that were within their control when they talk about population health instead of engaging with local public health. And so unless it's very specific that they need to engage with the governmental public health system to move the metrics and to move population health, we'll continue to have the same thing we have now with the governmental public health system having statutory requirements to move it and continuing to be under-resourced.
I think that's thank you for that. I think it's a great suggestion. I think it's our opportunity to raise exactly those issues to the Oregon Health Policy Board to say these are important issues in the future CCO contracts. So I think we have a really nice window of opportunity.
I just wanted to jump in and let folks know that Steph Jerem is coming to talk with Dr. Bainsberg in a couple of agenda items about the action plan for health, and that's really going to be the foundation for the CCO contract negotiation, so that's why we wanted to bring her here at this time and have this conversation. So for the sake of this agenda item, I just wanted to put that out there and let you know that we will have more time later on in the meeting.
Could I just ask, couldn't the Public Health Advisory Board make a formal request to our bosses, the Health Policy Board, to actually think about these things when they ponder on the CCO contract over the next year or so?
Yes. Well, I was gonna say, that sounds like a great idea to me. One question I was gonna sort of pose to the group is, how much detail do we want to have in that request? Do we need to have some additional discussion and maybe committee work before going forward to a request for the policy board? Because I had thought that this was something that was going to come up very quickly, but if it's a year from now, it might be good to take
It's a year from now, but there's a year's worth of work to do.
Yeah. Right, exactly. So there's.
But Jeff, my thought was that because we just actually approved the guiding principles for the collaboration between the CCOs and the public health system, we could use that as a frame for saying what kind of issues we see coming out of this kind of guiding principle document, and then just give them the idea that there may be one or two or three different issues that actually are relevant to think about. I mean, there are other things, for instance, I'm not sure it's actually the Public Health Advisory Board's table, but the inequality between the CCOs in terms of handing back incentive payments to the provider systems also affect the provider systems' ability to actually take up new ideas, for instance, with the public health system. So I think there are several issues that really could be part of that framework.
Right, that sounds logical, thanks. Jennifer, and then Katrina.
Yeah, thanks. Karen and maybe Lillian, could you just say a little bit more about the increase in the administration and management part of the budget?
Sure. That part increased because of a change in the way OHA does cost allocation, and there are 5 direct costs that used to be part of our cost allocation, but now are directly attributed to the program. So we put that in the administration and management piece. So it's about the same amount of money, but that's where it's showing up here.
Katrina.
Yeah, so I was just going to comment that, if I'm not mistaken, tobacco prevalence is one of the CCO incentive metrics. So I think there's a variety of, we're discussing a little bit about what the hook might be, and certainly measurement and how well they're achieving that. If it's the prevalence, then that does by necessity mean that they need to work with local health departments. So part of me wonders that certainly putting things in the contract, but also offering tools that would encourage that kind of partnership, because I think it's in everybody's best interest to make it happen. And even though we put the guiding principles for how collaboration should work, I think part of that means we provide toolkits to help them understand how that partnership can work and what kinds of things public health can do, if you will, outside the clinic walls. I know that CCOs are supposed to be working outside the clinic walls as well, but again, sort of more concrete tools about how that could work.
So Katrina, are there any tools in that toolkit, or would that need to be developed? I mean, are there any available tools that could be assembled into a toolkit, or does that need to be developed?
Yeah, go ahead, Karen.
Yes, we actually do have a tobacco toolkit that maybe be interesting to include in the minutes or something, but there is quite a bit of information that's available about ways that CCOs can contribute to a community approach to tobacco prevention.
Yeah, because I think the more concrete we can be about that, David, my thinking was the more concrete we can be about that, the stronger our recommendation to the board can be. Okay, thanks. Bob.
Thank you. Having been deeply involved in the CCO first contract, in fact, having written half of it, the idea was that they would really participate with public health. However, given the very short time we had putting it together, we had a hope and a prayer that they would do that. We've seen after 5 years that the hope and the prayer was not a great strategy, and the CCOs have been variably interested in public health, some very much so, some not so at all. So in this next round of CCO contracts, which is going to be next summer, I think this is one of several things that public health has a strong interest in. Another one being support of the Oregon State Public Health Lab. So for example, the CCOs are starving that lab, and that really is an incredible danger to our public health system if our public health lab gets starved out by the CCOs who are not using them. So I would suggest that we think about this carefully and do it. I'd also point out that the value of the metric on smoking is many millions of dollars. It makes this budget look small. So it's many millions of dollars, and clearly the idea was when we put the CCOs together that some of that metric money would go back to the people who are doing the things to get them there, including public health. And it goes for other things too. It's not just tobacco, it's also for immunizations. It's going to be for some of the dental measures. It's really the kind of things that public health can do to get there. So I would suggest we think about this carefully and make a strong and very principled case to the policy board so that they include these in the next round.
I'm actually seeing a lot of nodding in the room that that this is one of the few issues that we should take advantage of the opportunity. Yeah, and
I just want to make a process. So in order to achieve all this, I think just a process recommendation. The first stage of this one-year delay is going to be an assessment of the contracts and what is being implemented and what isn't, and to just have that kind of overview of the landscape across the CCOs, I think will be really useful. And that, Dr. Bainsworth can bring that here, and we can see where there are those gaps. And it's easy to focus on tobacco because it's so black and white. Thank you for bringing up the state lab. We have other big issues with outbreaks and emerging environmental issues where the CCO is making decisions they will or will not pay for things which are really public health interventions like immunizations. So, I mean, we have a whole series of things that can be packaged, but if we base it on what's happening now and where those gaps are, I think we'll have it'll be easier for the policy board to come up with a policy direction, because we need the policy direction, then, to get into the nitty-gritty of how to implement it through actual contracting, and then the contracting needs metrics. And I agree with you, Bob, the biggest thing we didn't have were metrics for a lot of those earlier contracts.
Are you suggesting a review of the CCO current contracts here for us to prioritize?
No, that's what the Oregon Health Authority will be doing.
Oh, we do?
Yeah.
But that information comes back to here for us
Right,
to
when you
identify
get
gaps.
it at your board, if you share it with us, it gives a better understanding. Right now, we have kind of anecdotal, information. Somebody knows what's going on in Woodward, or somebody else knows something that's going on in Yamhill, but this will be kind of a level set assessment. So I think that'll be extremely helpful.
And do you know when that's expected to be complete?
No, but I think when Stephanie comes, we can ask her. Because she's the main staff person.
I see. Right. Good time. So I'm just, I hadn't actually thought about the issue this broadly until just for the meeting. I'm very glad that the discussion is going this way, because the two things I remember most from the subcommittee meeting were preserving funding for county programs, and also pushing harder to get CCOs explicitly involved with health departments in tobacco prevention. So I'm glad to hear that the board's moving, feeling that same way, but it's sort of opening up the larger set of issues about public health issues that should be included in the CCO contracts, and thinking what should be our process as a board for identifying those things, because I've written down just like three, two other additional concrete ideas in addition to tobacco prevention that would probably be good, I'm thinking that, like either the staff or a subcommittee of members might review and then bring to this board for broader discussion and adoption into some sort of package. That's kind of what I'm thinking, but I have no more details on it at the moment. Katrina?
So just a thought, and this is clearly we're in brainstorming phase, so this is totally half-baked, but our state health improvement plan, in terms of the activities, there's a whole bucket about what health systems can do. So not that we would necessarily put all of our 7 priority areas in the CCO, but of course they're tobacco, obesity, substance use. I won't tick them all off, but anyway, that's at least a place to start thinking about which are the things that have health systems, because that state health improvement plan, there's population based, there's the health equity, and then there's the health systems pieces. So that's just, and some of those are becoming, I said incentive measures. I was thinking about the opioids, which I spent a lot of my life doing, but we specifically have a CCO toolkit, and it's become, again, it's a performance improvement project, a little different than an incentive measure, but there are inroads to those things that include what the public health system and the regions are doing in conjunction with their health care, viz. The CCOs, they're one aspect of health care. So anyway, that might be a place to start thinking about it.
So Jeff, sorry, go ahead. Okay. The only thing I was gonna add to that too is I think some of the conversations we're having in the provider group in Central Oregon are some of those things that public health does that's really behind the scenes, but yet we put a lot of energy into it. So all the communicable disease follow-up. There's a lot of other things that sort of may fall out of some of these specific buckets, but it's a lot of work public health does to save that system money. So I think I do think this is a much bigger conversation about where kind of crosswalk, what is it they're doing, what are we doing, and how does that coordinate to improve health?
Control of communicable disease is one of the issues.
Yeah.
Right. But I was thinking public health lab fits into, how
Right.
much do you want? But again, I agree with you, there's a lot of less specific things.
Yeah, no, thank you, that's another example that we've talked about in the past. So Rebecca?
Yeah, Jeff, I wanted to go back to my original question around
Oh,
the
sorry.
two subcommittees on accountability metrics and funding formula, which I think will be very important for the tobacco program. And I know we're going to need to wrap this agenda item up, but is there going to be a role for FAB, or do we want to talk about if those fit under our current subcommittees? And then I understand that the CCO conversation is very important. I also want to recognize that the tobacco program and public health, it's not just the Medicaid population in the healthcare world. Obviously, we've got our Medicare population, PABO, our employer-based groups, and so I want to recognize that in the cessation bucket, it's not, that little bit of money doesn't just serve the Medicaid population, that's for the whole state. So just being very careful about how we talk about that.
So, I'm sorry, so the question about.
So the question
I just wanna make
is,
sure I
Karen
understand your
mentioned that
question
you're going to be
about
forming 2 work groups to talk about the tobacco prevention budget, specifically around the funding formula and accountability metrics, which I think will be very important bodies of work. I heard that this will be a partnership between Public Health Division and CLO. I was wondering if the Public Health Advisory Board has a role in that, or if other stakeholders will be engaged in that process outside of the public health system, those 2 partners. Because this has come through FAB twice now, is that the direction that that FAB wants to have any say in what those 2 groups do, or is that just, are we done with this conversation, is my question. I'm kind of looking at Kara, or others, if we want to have an active role in how this works. I think our 2 subcommittees have been pretty theoretical, like if we had $15 million, what would the modernization funding formula look like? And this is a real example that the tobacco dollars can be used to have those hard conversations.
And my only response to you, Rebecca, would be that I don't know. This hasn't come up this way to FAB before, so I think it's up to the board to discuss and make some decisions about. This item specifically came to the FAB because of the budget note that was included in House Bill 5026. So that piece, I feel like after today, I think we fulfilled that specific letter of the law, so to speak. But I think it's up for discussion with FAB members what kind of a role you want to have in this.
So Rebecca, what are you thinking, like have FAB members on those work groups, or have a report back to FAB after they're completed?
I think that the 2 work groups, the funding, our 2 work groups have done a lot of work, so maybe there's some way that they can be connected. I just don't want to have another siloed conversation about how local public health is funded when we've had that conversation via our subcommittee for 2+ years. I think that's my only comment. But if it needs to happen separately, I understand that as well. I don't know if it needs to come through here or be a part of that subcommittee. I just don't want that work to get lost or duplicated.
So the only thing I would say is that so I'm not sure the makeup of those committees yet, but obviously we have CLO members that are part of this group. So there is that connection. It could be that somebody from this group is also part of that group. So I don't disagree with you. I think it's not a bad idea, but I think we do have CLO members on this too, maybe part of that. Maybe that's one of the things. We want to make sure there's somebody part of that group that's maybe part of FAB also.
Okay, so that's a good suggestion, that if there's a FAB member as part of that, one or both of those work groups, because there is overlap.
That's one way we could overlap there.
Okay, then,
Yeah, and just to clarify, that would be a kind of a corresponding subcommittee member is your recommendation, Rebecca, so somebody from accountability metrics, and somebody from incentives and funding.
and then, so Karen, when are those decisions going to be made by those work groups?
Well, the decision for the current biennium is made, so we can move forward with our budget if FAB agrees with the recommendations. Those work groups are yet to be formed, and we plan on these conversations lasting for probably the remainder of the biennium. And hopefully we'll have a really good idea of where we're going before the next biennium starts.
So Karen, so there's two pieces right now before us. It's the now, which you have in front of the spreadsheet. And then do you just want to like recap what are the three elements that are going forward in the work that these subgroups are doing?
Sure. The work groups going forward are identifying what are some accountability metrics that county health departments can hold themselves accountable for the current biennium. What are some of those things that we can all agree are things that counties receiving TPEP funding will do? And then the other conversation is really looking at the CLOVE funding formula and how funding is distributed to local public health for tobacco prevention.
And so is that, just to connect it back to what we have, are you talking about the formula that distributes the $9.28 million in that column on the spreadsheet?
Yes, it's a portion of that. And that's one thing I think that we will need a much larger discussion. The state and community interventions piece of a comprehensive program seems to have morphed into funding for local public health, and it's much bigger than that. It is how we fund tribes, how we fund regional health equity coalitions, how we have statewide interventions so that we can reduce tobacco use in Oregon. It is much broader than just funding for local public health. And that is what I'm hoping that working together we can come to an understanding about what those funds, how they can best be used to reduce tobacco use across the state.
So is there any interest in the board of, to hear about the progress of those discussions over the next year or two? Or over the rest of the biennium? Yes, I guess, Karen and Kara, would it be possible for FAB to hear an update about those things after, because I think the way you frame it, Karen, makes a lot of sense, and that's actually very consistent with modernization, is to think about if we have a pot of money, what's the best way to spend it. And I think that I guess I would, as a board member, I'd like to be able to hear about those discussions as they go on and be able to provide feedback. Eva?
Because of just coming back, I want to make sure I'm understanding properly. So this time around, this chart is using the existing funding formula to give money. But you said something just a minute ago about for the local public health authorities that are receiving TPEP money. So I guess I just thought maybe not everybody was receiving it then.
No, all counties in Oregon receive tobacco prevention money, and the funding is distributed through a funding formula currently. That funding formula is likely not the most effective way to distribute funds to reach the outcomes. But that's a discussion that we need to have. But it's been the same funding formula for about 20 years, and it's a very, it hasn't adapted to the way things have changed, and it might be nice to look at a different way of funding local public health for tobacco prevention.
Yeah, I guess if there are proposed changes to the funding formula or associated metrics, I think FAB would be interested in hearing about that and being able to provide feedback as those plans evolve.
And can I go back to
Sure.
Rebecca's comment, because it's light bulb just went on just now. That it might be helpful to have the funding and incentives funding formula that we had come up with presented to that committee once they get established, and just let them know all the work and research that went into that, because it's we did that with the preparedness funding formula, and we weren't, the subcommittee wasn't ready, the CLOFAP subcommittee wasn't ready to take that on, but I think it really brought up some really good discussion points. So if that's a possibility, I'm sure that we could do that, somebody from our subcommittee plus a staff member.
Yeah, that was one of the options that was presented, but also the group was not ready to make that kind of a change at this time. But several different options were presented, but again, we weren't ready to make the change at this time, so we're sticking with the current funding formula, but some of those other options were definitely intriguing. And when we had the more in-depth conversation between CLO and Public Health Division, I think a lot of good ideas came out of that are not the current funding formula.
Okay, this topic always.
It's smoking.
Exactly, it is.
There you go.
So I think, have we as FAB done what the budget note requires there? Okay.
Yes,
All right.
thank you.
Thanks, so, and we'll do more about this in the coming months, thanks. So we were scheduled to take our break a few minutes ago, so let's go ahead and take our break and try to come back around 3:45 and talk about accountability metrics, and Lenny will present to us about that. Thanks.
There's two people there.
Welcome back, everyone. Let's, our next item is returning to the topic of public health accountability metrics. One of our responsibilities under the modernization legislation was to adopt accountability metrics. At a prior meeting, we adopted several outcome measures in a few different domains based on real detailed work that our accountability metrics committee had done in collaboration with CLO and based on input from actually a couple of hundred stakeholders. So the next phase of that was to identify process measures that could be implemented to measure progress toward those outcomes. So again, the metrics subcommittee has been hard at work on that, has brought us some recommendations. So this is an item that we will vote on, and Mighty is going to walk us through the work of that subcommittee and their recommendations.
Thank you very much, Jeff. That was a great introduction. That saves me a few words because I was going to say some of the same things. So as Jeff mentioned, back in the summer several months ago, the Public Health Advisory Board voted to adopt the accountability metrics associated with population health outcomes. And so now we're here to talk about kind of phase 2, which is the local public health process measures that will be used to measure progress towards achieving those population health outcomes. So the purpose for today's presentation is to review the measures that have been recommended by the FAB Accountability Metrics Subcommittee, and then to vote to adopt process measures. And in your packet, you have a couple of materials. One is the slides. Another is a 2-page summary of the process measures. And then there's also a detailed table that provides some information about the rationale for each of these measures, some of the existing funding, where these measures can be measured, some highlights from the different conversations that have been had regarding these measures and how we got to where we are. So depending on your level of detail or not, you can follow along on the slides and the 2-page handout or in the more detailed table. As I go through this, I will maybe highlight just a few things from the detailed table so that you don't have to read it and process it, all of it right now. Next. So just as a refresher, the public health accountability metrics that you adopted back in June are within these 4 foundational program areas of public health modernization. Within communicable disease control, it's the 2-year-old immunization rates, gonorrhea rates. Within environmental health, it's active transportation and drinking water standards. Prevention and health promotion is adult tobacco use and opioid overdose deaths. And access to clinical preventive services, it was the effective contraceptive use and dental visits for children 0 to 5 years of age. And again, these are the population health outcome metrics that focus on those population health priorities that public health has a role in improving and moving towards. So this is a graphic that you may have seen before. So the accountability metrics process has been in 2 phases. One, the outcome metrics, and today we're focused on this right-hand side of this graphic here about the local public health process measures. And these process measures reflect the activities of local public health in conjunction with or with the support of state public health to achieve those population health outcomes. And there has, through the process of discussing these process measures, there has been often some confusion, might be a little bit too strong, but some interest in distinguishing between what's a process measure versus an outcome measure. And this just gives a brief example of a logic model for gonorrhea rates. And so it kind of starts with the structural pieces. What are the inputs that lead to, that allow you to perform the activities, which is kind of the second box there. These are the activities of both state and local public health that will have directly, kind of immediate direct outputs And that's kind of highlighted here in the middle, which are these outputs or process measures. So that's where we're focused today. The gonorrhea rates, as you can see, reducing and decreasing gonorrhea rates is a long-term outcome, and that's what we're working towards. That's the accountability metric. But the measures that we'll be talking about today are really kind of this more intermediate, short-term process measures related to the outputs of the activities that are performed to get there. So there was a bit of a process that was involved in getting to where we are today with the process measures that we'll be talking about. From July through September, CLO, the Coalition of Local Health Officials, the committees, so the committees, including state and local subject matter experts, reviewed a lot of existing measure sets and some deliverables in the Public Health Modernization Manual, and as a starting place to develop a set of the first pass of the process measures. The committees that met to discuss these were the CLO Healthy Families, the Healthy Communities, the Communicable Disease Committees. And from there, after many meetings and discussions, some measures were recommended and reviewed by the full CLO, and the full CLO then proposed a limited set of measures to the FAB Accountability Metrics Subcommittee, which then, of course, reviewed and discussed. And today, what I am presenting to you is the outcome of the FAB Accountability Subcommittee's recommendations for approximately 1 to 3 process measures that are associated with each of the accountability metrics. So I'll stop right there because that's just a lot of kind of background and kind of process about how we got to where we are. Are there any questions before I jump into exactly what those process measures are, the recommended process measures? And I had a brief conversation with Jeff prior to starting here today, and what I thought I would do is walk through all of the process measures. Certainly, if you have some questions or you have some additional items that you'd like to discuss about them, and then we will, at the end, you will vote to adopt all of them. Or not, yes.
Or not.
Yeah.
We'll vote, but I sort of asked, since we have the table and the slides, I asked Mighty to sort of, go through them fairly quickly, give us a chance to ask about each one, and at the end, we'll consider the slate. So thanks.
Thanks for that clarification. Okay, next. So here's where we can, potentially follow along with the table, and as I mentioned, I can highlight a few items that were mentioned during the process of coming up to these recommendations. So for the 2-year vaccination rate accountability metric, the recommended process measure is percent of vaccines for children clinics, and maybe within a subset, the clinics that serve populations experiencing disparities, that participate in the Assessment, Feedback, Incentives, and Exchange, also known as AFIX program. So the AFIX it's an evidence-based intervention. There's kind of a number of rationale items here. It has the potential to build and enhance partnerships with healthcare providers and with CCOs. It does line with strategies of some of the CCOs for increasing childhood immunization. It also is an area that highlights the collaboration between state and local public health, and there's an established data collection mechanism for this process measure. There is, all local public health does receive funding for immunization services, but there's no specific requirement for participating in implementing AFIX. And there was also, just some discussion about the fact that although some local public health officials were concerned about the ability to have direct control over healthcare provider participation, there was also kind of some enthusiasm for this as an opportunity to build those collaborations and to work with CCOs. I'll move on to the next one, gonorrhea rates.
Actually, I have a question on this one. How do you determine whether they serve populations experiencing vaccination disparities? That's not impaired.
one of the, kind of the next step beyond after today is to operationalize these process measures. And so two things to say about that. One, determining how we actually determine the clinics that serve populations experiencing disparities. That will have to be operationalized, and that's really a next piece of work. This is included in here because some counties have a large number of vaccines for children's clinics, and this was a way to potentially limit the scope within those counties that have a large number of those types of clinics. Okay, if there's no other questions, we'll move on to the process measure associated with gonorrhea rates. So the subcommittee recommended two measures in this area. One is the percent of gonorrhea cases that had at least one contact that received treatment. And the other recommended measure is the percent of gonorrhea case reports that have completed priority fields in the Oregon Public Health Epi User System, Orpheus. And those priority fields are pregnancy status, HIV, most recent test date and status, gender, sex partners, and proper treatment of gonorrhea. So regarding the first recommended measure, the cases that had at least one contact that received treatment. This is treating cases is an evidence-based intervention for gonorrhea, for stopping the chain of gonorrhea transmission. And it is consistent with the activities that are currently in the program element for local public health. And of course, there's an established mechanism for collecting this kind of information. With regard to the second item, it is an indicator of the quality of data collected, and it's also can help to identify where disparities exist and potentially inform targeted interventions. One of the items that was discussed, I believe, within the subcommittee, there was a couple of other measures, I'll back up a little bit, a couple of other measures, process measures that were also discussed with under the gonorrhea area. And potentially one of them was looking at, like, say, the number of FTE, and that could potentially be considered, going forward. But one of the things with regard to the data system piece, it was brought up that there needs to be a statewide approach to training to be able to provide local public health with the assistance to be able to kind of move forward in that area. And that kind of calls attention to maybe some of these other process measures as well, is that the emphasis on the kind of state-local partnership with being able to achieve these areas of process measures. Okay, moving on to opioid overdose deaths. Oh, excuse me, for adult tobacco.
Back on the gonorrhea, so on page 46 of our packet is the table, and you mentioned additional measures, but you didn't talk about the number of community-based organizations. I think that was with the partners that are engaged. I'm just curious about how that conversation went. I don't see that as another consideration under the other accountability metrics. It just strikes me, I'm thinking, I attended the community meeting in Portland, and there were several community-based organizations represented there, and so I've just been thinking a lot about how we measure how local public health and the state health department are at outreach efforts and engaging community-based organizations. So not just specific to gonorrhea, but I was wondering if in your conversations there was a discussion about how you would measure that.
So with regard to the subcommittee's recommendations here on the first two measures, and these last two are just included here as because they kind of bubbled up to the very end, but they were not selected as for the final recommendation, and possibly because of the difficulty of measurement. Thanks for your question.
Yes, I have a comment, if I may.
Sure, go ahead,
So, I'm sorry, I don't think that I actually had noticed that footnote on page 51 at the bottom to one of the gonorrhea rates, where it says for areas where no established data collection system exists, each LPHA would be responsible for creating and supporting an internal mechanism to collect the data. I just have a very serious reservation with that sentence. I'm sorry, Carrie, if I didn't notice that it has been on our table all this time, but I think that this probably would create a level of unstandardization that we would not be very interested in. I mean, the whole metric system in the state has been focusing on trying to use standardized sort of metrics with statistics, specification sheets, and so on and so forth. And I'll get back to this when we talk about the dental data. But I mean, I think this is a really a mud pit that we should try and stay away from. I mean, we need to set up a system where LPHAs would be recording or reporting data that are comparable and valid and reliable and so on and so forth. I mean, if we get like 33 different ways of collecting data, then it won't be of any use to anybody.
So Ely, I think that's a great point. I believe that the two recommended measures, I believe that the footnote applies to the two measures that were not the recommended ones, but for the two recommended measures, the existing Orpheus data system will supply data. Is that correct?
That's correct, Jeff.
Right.
So,
yes, but just a small counter. I mean, when you look through the document, you'll find a whole bunch of metrics and proposed metrics where it says LPHA reporting, and when you actually try and dig a little bit underneath that, you will know that the LPHAs actually don't report that or don't record that at the moment, which means that a whole new system needs to be set up. And that means that this footnote essentially could gather or could count for all of the LPHAs reporting in the entire document.
So Ely, this is Mighty. So yes, I'm glad you're pointing that out. I think that is an important consideration that for going forward and collecting these data that we, potentially look to the extent possible where there are existing data. There's a few areas that are kind of emerging areas that really have no data systems available at this time. And so active transportation is one area that that's the case. For looking at those process measures. But anyway, we can kind of discuss that a little bit more when we get there. But I think it is an important point that, where data are available, it is something to attend for your attention as we go forward in this discussion.
All right, yeah, that's, okay, well, thanks. Mighty, if you wouldn't mind pointing out, as you go along, if there's a recommended measure where there is new reporting required, just highlight that, please. Oh, Eva.
I was just going to jump in and add, and this might not be the exact right time, but when we discussed number 4, that's listed on page 51, the FTE, the number of FTE trained, we had a pretty big discussion about the FTE and how it might be helpful to have that kind of information across all areas so that we can get a better idea of how the decisions are being impacted at the local level for who's doing what and when. And we weren't sure how that would work out all the time, but it was conversation.
Makes sense.
Okay, thank you for all of your important comments. And if we're ready, we can move forward to the prevention and health promotion area for the accountability metric, adults who smoke cigarettes. And the recommended process measure is the percent of community members reached by local, potentially tobacco retailer smoke-free, but local tobacco-related policies. As many know, that the Policy focus aligns with the CDC tobacco prevention best practices. Policies change, of course, is one of the strongest levers for reducing tobacco consumption, and there is currently an established mechanism for data collection regarding tobacco policies, and that is the local tobacco prevention education program, TPEP, grantee reporting, and as was mentioned earlier, all local public health receives funding through the program element for tobacco prevention and education. And there's also the Health Promotion Chronic Disease Prevention section has a policy database that maintains information about local tobacco policies. So that data collection mechanism is there. One of the areas for discussion around this potential process measure was related to the variation across localities and local health departments for being able to because of the feasibility of passing to local local policies related to tobacco. And so as we operationalize this measure, we will keep in mind and try to be flexible for addressing differences in tobacco policies among all the different counties.
Katrina?
Yeah, just a question about this. What's the definition of local policy? Were you talking about a specific ordinance that gets passed?
Yes, it could be.
Well, so I think it's really important to clarify what it is we're trying to get people to do. Because, for example, our house is a total smoke-free policy. Well, my husband and I have never smoked, nobody, so it's not actually all that useful that we have a smoke-free household policy because it doesn't, it impacts all of us, but we're not helping change any behavior necessarily. So anyway, I just want to be, devil's in the details.
So yes, devil's in the details, and I think the next phase of this is we operationalize these process measures that will be, part of that conversation. The other is, for potentially consideration here is what is eligible to be reported to the HIPAA policy database, and I think that they have some criteria for what is reported there, and I think that we will follow those criteria.
Let me just add, I have, for both cigarettes and we get contraceptive use, there's going to be a lot of heterogeneity in policies. And there could be good policies and bad policies. And just, even if we assume that all these policies were good policies for people who smoke cigarettes, but the heterogeneity of those policies, how you measure the number of community members, it's going to be hard to measure that and get a number that means something. And even if they are good policies, but if you have good policies and bad policies, the number of people reached by bad policies, get more people reached by bad policies is sort of moving us in the wrong direction.
Yeah, this is Rebecca. That's an interesting thing too. I was thinking about strength of policy because, you can pass some bad or just policies that don't make any change or have any impact. And as a process measure, again, I keep thinking about community outreach. Is there something more of demonstrating that the local public health authority is making progress towards policy change, or that that's the number of times they've presented to something or engaged communities? Because you could have a lot of really great policies already in place and have 100% of your community members are covered by Tobacco 21. So the whole state's covered by Tobacco 21. What is that demonstrating in terms of accountability is sort of my question. So.
Could I just, I'm sorry for jumping in, but I think it'd be helpful maybe at this point to kind of frame this particular conversation up in the bigger realm of public health modernization systems change. So these measures are kind of one piece of the puzzle, and as Mikey mentioned, there needs to be work after today to actually come up with a definition and measure, specifications, data sources, et cetera, for each of these measures. That's really important. I think another piece that's been discussed is identifying what are the inputs that go into these process measures. So there's still other layers of work, and Rebecca, I think to your point, a lot of that working with partners and making sure that you have a good community footprint is really important to even get to this point. So what are those kind of subsets? So that's one piece. And then we're also in the process of looking at the program elements of the contracting mechanism between state and local public health. They're going to be cross-referencing where there are currently funds available, these measures. Now, we also have some measures that we've adopted that actually are not funded at this time, so they will not be included in those tools. But sort of beyond that, there are opportunities to include other measures that are important that would be monitored through that contracting process. Are there any questions?
Oh, go ahead, Bob. Yeah.
Did you consider the tipping point effect? I mean, obviously, to put the first tobacco policies in a county is very much harder than if the county is 99% smoke-free and getting the last percent. In fact, Gladwell's article on tipping point was specifically about tobacco policies, and he said how hard it was to do in the beginning and how easy it is to do in the end, the idea that the wall's almost down and gravity is helping you. So is that going to be a consideration in doing this?
Yes, as we kind of move forward to determine like what is a criterion for success, if you will, and what is ultimately, first of all, I think we need to kind of establish a baseline about what's out there, and I think that will be kind of the next step after we operationalize these measures. Then it will be, a process of determining, well, what is a good indicator of change, or what is an indicator of kind of success, or moving towards a benchmark. Ultimately, if there is funding and these, are kind of part of the incentive measurement process for modernization funding to local public health, then we, of course, will be very attentive to what is a good criterion for measuring change or success on these measures, but we have not gotten there yet.
But actually, I'm glad to, I like this measure because it is a policy and system change measure. I don't think that any others are. And I think just tobacco control is probably the area of public health policy that's most developed. And so I think the base of evidence about of effective policies is probably strongest in this area. So the fact that we've got an evidence, that there is a pretty good evidence base and a measurement system already in place, I think I'm glad that we're able to take advantage of that for a measurement.
Yeah, I agree, but there is a challenge, however, in addition to the potential bad policies, which I think the risk is lower in this field, but there's an issue of enforcement, and so I'm wondering if there is a way to track or measure how those policies are enforced on a local level, whether that's by level of funding or some other metric in terms of the resources allocated to that piece.
Yeah, good point. Thanks. Okay, yeah, Mighty, go ahead. Yeah, go ahead. I think we've got a few more.
Move on?
Mm-hmm.
Okay, so the next accountability metric area is the opioid overdose deaths, and the process measure that has been recommended for that is the percent of top prescribers enrolled in the Prescription Drug Monitoring Program, PDMP. And the PDMP is a tool that's, of course, used by almost all states to promote safer prescribing practices. It's consistent with activities in the program element currently, although not completely statewide. It does represent an area of state and local partnership. There is, of course, data available in the PDMP database.
Just one question, it's a good idea and we're doing it. Is there any evidence base behind it? When we looked, we couldn't find any.
I think you may be correct, maybe that we're just kind of early on in the data collection phase and we don't have the answers yet.
So,
Oh, go ahead.
I can address that slightly, but you're absolutely right. It's a multi-step process. The first is who's enrolled and do they check it, and then are they following guidelines, et cetera. So there's a number of things that prescription drug overdose program is looking at, and this is one step, but they're, you know, the issue is that we are potentially, so I sit on the governor's task force around opioids, are potentially coming up with some new legislation that might, for example, mandate enrollment. So then this process metric wouldn't be that useful. But you're absolutely right. Just being enrolled is not necessarily sufficient to change practice over the long run. But, well, what's the word? Necessary, but not sufficient. Anyway, so it is one step.
And we've seen that.
Yeah.
This sort of, I mean, I think this is, Katrina, you may have been involved in some of these. This is sort of like the third committee I've been on where we talk about opioids as a really important public health issue, but coming up with a measure that actually makes sense in practice is really, really hard. So, I know this seems like a good step, but
Yeah, so just,
It's a
you
small
know,
step, yeah.
I mean, I can talk about this for hours, but there are different ways. So certainly enrollment would be one. Another would be, because we do know that it varies by region of the state a lot, and a lot of our activities are by region. You could look at the percent of patients that are receiving over an MED, that's morphine equivalent dose of 120 or 90. Those are some of the CCO metrics, and that would actually align. So again, I'm happy that you all are thinking about this, and I don't have a particularly strong feeling that there's another one that's much, much better, but certainly the percent of patients on a high dose would be kind of a process measure. It's also kind of an outcome, although the real outcome that we're trying to prevent is overdose and death. So.
thanks.
Okay, thank you for your feedback, and I think we'll move on to the next area. In environmental health, we have the two accountability metrics there, the active transportation and drinking water standards. Regarding the process measure associated with active transportation, if you will recall, the active transportation accountability metric is the percent. I believe we kind of had some conversation ensued after the adoption of the measure in June, but the percent of commuters who walk, bike, or take public transit to work. And I, wanted to just have you recall that this is a sort of a transformative measure. This is something that's kind of moving forward in this area, that it's not something that we have, well-established data collection systems and established mechanisms for the partnerships with transportation and public health, but it is an area that's forward-looking and it's actually moving forward. So with regard to the process measure associated with active transportation, the recommended measure is the number of active transportation partner governing boards or leadership boards that have local public health representation. So just to point out that there is no existing data collection mechanism for this, and so we would need to establish how we would measure that. It is an emerging area. It's kind of bringing us closer to the progress towards establishing partnerships between public health and transportation. It also aligns with the guiding principles for public health and healthcare collaboration document.
So I may be ahead of the game here, but the number is always a concern with the different sizes in whatever counties. I mean, Multnomah County probably has 500 transportation boards, so being on one or two would not be a big deal. There's probably one in Curry County, so 1 out of 1 would be a whole lot better than 1 out of 500. So there are several number measures here, and I think we have to be careful given the different size and complexity of the counties.
Yes, I agree, and I think as we operationalize this, a lot of these number metrics will turn to proportions. Yes, we'll need numerators and denominators.
Yeah, so my question about this one, I really appreciate that a number of these are looking with those partnerships, because that's what we've been talking about all along, is that we can't do it by ourselves. We need to figure out how public health works. But I was going to actually ask, do we even know whether some of the very rural counties have an active transportation, or some of those might be regional? I don't know the answer to that question, but so I'm wondering whether some counties even have the ability to do this. I don't know.
So they are required to have a TSP plan, and so it's different in every county, but I think when we talked about this, we even said if a commissioner sits on it, or you have someone who's representing what you're doing, but I think all counties are required to have plans, transportation plans. So that, I don't know if that's considered a governing board exactly, but it is a group that comes together and makes decisions on those plans. So ours just was approved for 20 years last week. So.
So on the metrics and scoring committee, we had the ability of CCOs to earn a incentive either by meeting a target or by making a minimum level of improvement toward the target. So that's another thing I would suggest, Mighty, is that, in some counties, it may be very difficult to build these sorts of partnerships. So getting the first one or, adding a new one that doesn't exist may actually require a lot of work by the local health department, and it would be something that I think they should get credit for.
Well, we actually don't get funding for this currently, so I think that's the other piece, there's not funding for this.
Okay, next.
Moving to the, excuse me.
The next area under environmental health was the drinking water standards, and the process measure set that is associated with the drinking water standard metric are number of water system surveys completed, number of water quality alert responses, and number of priority non-compliers that are resolved. So these three process measures kind of hang together, and the I think it's Safe Drinking Water Work Group thought that these measures, really accurate or well reflect the work that's currently being done. And it's important to point out that although that they are included under the existing program element, there's resources are limited and there's still room for improvement in this area.
I think there's the same concern about numbers versus proportions in 2 and 3, because if you could have a lot of complaints.
Agreed.
Yes, very good. Okay.
And Mike, do we have evidence that, or do we have information that suggests that there is, I think you just said last year, make sure I heard it right, that there is opportunity for improvement on these measures?
Yes, to my knowledge, as of this time, yes, there is room for improvement.
Okay, good.
Okay, next, the last area is the access to clinical preventive services area. For the first accountability metric, effective contraceptive use, the subcommittee recommended that that the process measure be number of local policy strategies for increasing access to effective contraceptives. I will point out that although this aligns with the Public Health Modernization Manual, core functions for assuring access to clinical preventive services, and it does align with the CCO incentive metric. There is no existing mechanism for reporting on this process measure. And, again, there's the conversation that has ensued, throughout this process of the concern about relying on participation from the healthcare sector. Although it does represent an opportunity for trying to work to move the two systems to work together, and it of course is this reflects the public health assurance role.
Sure. My concern with this is not a lot of heterogeneity policies, bad policies versus good policies. So we certainly wouldn't want to have 5 bad policies is not better than 1 good policy. Yeah.
I don't want to open up can someone give me 2 examples of what a local policy would be around this area? It's just not my area of expertise, I'm just curious.
We, for example, had really stressed that you do the 1 key question.
Yeah. Okay.
So you operationalize 1 key question, and whether a childbearing age, you say, are looking to be pregnant the next year, and if the answer is no, then you say, well, what you do about it? A little more sophisticated.
Yeah, no,
Yeah.
I am also curious about whether access equals use.
Could you elaborate a little bit more?
Well, the policies are for access to effective contraceptive, but the effective contraceptive use, it's really effective contraceptive access. It doesn't, I don't know if they do, if you have access to effective contraceptives, does that mean that they use?
Well, there's a continuum of adherence.
Right.
Access is that first step.
Right.
But it's not the only step. So I think it's important, it's an essential first step, but it doesn't ensure use.
Yeah, I'm glad. And I just, yeah, I also have the question about what the evidence base is about local policy strategies for contraception. It's not something I'm that familiar with, so there could be, but I just, yeah.
And you mitigated my concern about the smoking one, that there's a science there, and I think the science here is less developed.
Right, or at least among this group, less clear. Yeah, Katrina.
Well, I don't know the explicit answer to that, but I was thinking about things like school-based health centers that might make them available, or the availability of a Planned Parenthood, or those kinds of things in the community. So again, I think necessary, but not necessarily sufficient. And to this point about, does it mean they use, of course, the access, it's really about the discussion and the choice, not necessarily that people are all using contraceptives, that they're using it if they want it.
And, and I think an earlier conversation that we had around this, one way that local public health can use this in their own communities is with the data that is provided in terms of outcomes. If you have rising rates of teen pregnancy, et cetera, you can use that for the conversations and present it more, one practice will know what's going on. To your point, well, I gave everybody, a condom, or whatever. Or everybody in my practice, I thought I referred for a lark. I don't know what happened. Well, we can actually give them feedback on that might change practices, or it's a strategy to just make providers aware of it, or prescribers aware of it.
I recommend, I just told all my patients to say no.
Yeah. So we'll have some data.
Yeah, exactly.
That one for you.
So I think one of the other areas in this, which is a little bit of a stretch, but I think it's also important, and where I sort of think about this, is also working with your school districts, making sure kids have access if they need to, but also what curriculum are they using that's age appropriate in the school district. So there's a lot of things that you can kind of fit into this in that realm too, especially if we're talking about teen pregnancy.
This is Terry.
Oh, go ahead, Jerry. Oh, go ahead.
Just an example of what we're trying to do locally is we understand from client and partner agencies that there's still limited access to primary care because we just don't have enough providers in the region. But yet both health departments who have active reproductive health clinics have more capacity to see clients. So we're trying to work with local systems to see public health reproductive health as specialty care and set up referral processes so that we can get people in quickly when they have a contraceptive need and not wait 3 weeks or 3 months to establish with a new provider and get those contraceptive needs met, and then help kind of case manage them back to their primary care physician for ongoing treatment. And that when people call and say, I had unprotected sex in the last 72 hours, and but I weigh over 194 pounds, and the only thing that's going to work for them is a copper IUD placement, that we, as a system in our community, know where to refer a woman so that she doesn't end up with an unintended pregnancy. So, and there's really very little communication among providers right now and coordination. So I think there's a lot that can be done so that we really increase access. And I think the evidence is pretty clear that when women have more access, they use more contraception. And we have fewer unintended pregnancies. I mean, our abortion rates right now are lowest that they've ever been with the ACA. For today, I think we've got good things in place, but there's a lot more we can do.
So, yeah, I think there have been some good suggestions, but I think this is one where I think some effort is really important. Effort in measurement will be really important in developing measures.
Could I just have a follow-up to Terry's comment? This is Ely. Because I think there actually hasn't been much in this presentation and discussion about the collaboration between the provider system, the CCO system, and the public health system. And as you all know, several of these metrics that we have been proposing are actually overlapping one way or the other with the incentive metrics that exist for the CCO system. And one thing that comes to mind, listening to Terry, would be that maybe what we could ask the authors of these collaboration sheets that you are producing now was to focus on these areas that we are proposing as accountability metrics, and maybe ask whoever are doing them to actually identify areas in the state where some of these collaborations take place, and let us get them out there as examples of collaboration so that they can inspire local public health agencies as well as CCO people to actually pursue these kind of collaborations, which would then both help the CCOs with their metrics and would help the public health agencies with something new, which would be accountability metrics.
Yeah, I think that's quite consistent with the discussion of the things. Okay. Yeah, Alejandro, perhaps one last question.
One last question. This one strikes me as really that effectiveness on the policies will depend on sort of the culturally responsiveness of those policies. In other words, how are those policies implemented, particularly when you have diverse populations? To what extent was that discussed, or did that come up, and is that something that is feasible to consider in the context of, policy strategies? So in other words, are there policy strategies that include sort of a culturally responsive element to it?
I was not present for the discussion on this one, so if someone from the subcommittee has some additional information to share, that would be great.
I think when we originally had some of these conversations, some of that came up, but I think it sort of depended, like I'm working on this metric to my CCO, so I have a very different perspective about, we're kind of doing this all the time, we meet twice a month, blah, blah, but I think we do talk about that. We talk about the whole region and how are we serving clients in all 3 counties, and so I think it's, as a public health agency, that whole issue is important to us. So I don't know if we built it in, but I think it's sort of, I hate to say it's what we do in public health, but we have those discussions a lot at the local level about how we're serving all the clients.
I think it gets back to a good policy versus bad policy.
Right.
So that would be a good policy. If we have 5 bad policies, it's not better than one good policy, one culturally informed, effective policy that actually changes behavior.
Yeah, but I'm also thinking that a policy that's very effective in an Anglo community might not be so effective in a Latino community that the policies may need to be tailored. So I guess I'd suggest that is also one of the criteria for the group to consider as they're developing measurements for this. Specifications for this measure.
But I think that applies to really all of them. I think it applies to many of the measures, so.
Okay, Jen.
Sorry, so Mighty has the patients of the same, so do the rest of you, but I'm sitting here wondering, what if we used gonorrhea rates as our access to clinical preventive services measure, and the percent of gonorrhea cases that had at least one contact that received treatment? That is an access question, and the public health role is either make sure they can go somewhere to get it or provide it yourself, but that's a more direct measure of public health linked to an access issue.
That's a better measure. I agree it's a better measure, but I really like having a contraceptive use and access as a target area. I think it's a really important area to address. I'm just concerned about the choice of process measure here. I wouldn't want to lose that area.
Yeah, just like the discussion today, I think we had several concrete, suggestions that I think would be good things that we would want to encourage.
Do we vote on these individually or collectively?
I was anticipating that we would vote on collectively. I know this has taken quite a bit longer than we expected, but I'm hoping that by having sort of an in-depth discussion of each measure, we'll be able to, have an informed vote. But I'm sorry, what I was envisioning was that we would vote on the package, but we may choose to modify the package.
I commend the committee's work for it has some very informed measures. I think it's really intelligent work. Thank you very much. I would vote in favor of all of them except for the last one.
Which
is the contraceptive measure.
Okay. All right. So let's.
We haven't done dental yet?
Yeah, we have one more oral health. Okay.
And with regard to oral health, this may be easy or not easy, but the subcommittee has recommended that we do not adopt a process measure at this time. And, the recommendation is to continue to explore the public health's role and functions for increasing dental visits. And, some of the conversation from the subcommittee is that these, there were some process measures proposed and discussed at great length. And there was just some thought that they were just really too weak to believe that the process measures would actually lead toward the ultimate outcome, which is dental visits for children 0 to 5 years old, and that there are significant access issues, even, say, one of the process measures was regarding referrals, and there's still significant access issues, even if the referrals are made. And, there's just a lot of barriers for the process measures that were discussed to be meaningful. So the subcommittee's recommendation is to not adopt a process measure for oral health.
Thanks, Mike. Can I ask?
I have a comment to that.
Yeah, please, Healy, may I ask you a question before your comment? And maybe you're going to address this. What would it mean to have this as an outcome measure but not have an associated process measure? So go ahead, Healy, please.
Well, I mean, I'm not sure that I actually consider this an outcome measure. I actually think it is a process measure. The outcome measure would be the percentage of children 0 to 5 year olds who had a dental visit within the last 12 months.
Okay.
And you could go further and say, to the extent that these children are carriers free, but that's sort of probably to go a little bit too far. But what I wanted to say, because I thought the presentation was very fair, so to speak, to the discussion we had. But I do think that it is important, for me at least, to highlight that the local public health agencies at the moment are very rarely involved in dental care. I mean, we have a couple of counties that are heavily involved, like Multnomah County and Clackamas County, but I don't know many counties that are actually involved in this. They are involved maybe through the dental care organizations or the CCOs and so on. So I think that there are a number of activities that need to be taken before we would come back with a better measure. So that's really my reason for suggesting that we should not adopt it at this time. But my next question then is, what happens with a measure like this that we don't agree on and we don't adopt? What would be the process? Will we continue to discuss it in the subcommittee, or will it just be lost by the wayside? Because that, of course, I wouldn't want, since the 0 to 5 year olds is a very important population group.
Yeah, thanks, Healy. That's actually, you just said more succinctly the question that was in my mind. If we don't adopt a measure now, will the subcommittee continue working on that? I mean, the analogy that comes to mind for me is that, again, from metrics and scoring, is that we had on deck, what we called on deck measures that were issues that we as a committee thought were important to measure. Like, for example, kindergarten readiness is the one that has been on deck for quite a while there. But we thought they were important to measure. We wanted to include them, but there wasn't a good enough measure at the moment. And, work would continue, and, the committee was eager to be able to include it at the time. Are you thinking something like that? I mean, to call it on deck.
But I'm also thinking that in other fora, other corners of the Oregon Health Authority have actually produced a statistic that goes crisscross the usual statistics that we get. And for instance, for the 0 to 5-year-olds, in an oral health report earlier this year, they were actually able to extract information that did highlight to what extent medical providers, for instance, provided preventive care to 0 to 5-year-olds. I mean, so some of these things we really didn't have time to go through in the subcommittee because we were under certain time pressure. But I really think that it is worth our while to have some place on the agenda and to continue discussions in the subcommittee to discuss it.
Okay, thanks. Well, I guess, would it, one thought I have is that we could adopt, we could vote about some of these measures, and if there are some that require more development, we could, not adopt them today, but ask the committee to keep working and come back with more specific measures instead. Okay. Okay. Would anybody like to make a motion along those lines?
I'd like to make a, thank you. I'd like to make a motion that we vote on 2-year vaccination through drinking water. Because I think I heard consensus, a lot of enthusiasm over those.
Okay.
And then leave the others, then we could vote on the others too, separately, but, or just, and if they're not passed, then we wait for, ask for the committee come back.
Okay. Is there a second for that motion? Yes. Okay, second. Thanks. So discussion or suggestions or amendments about that motion? David, could I just ask a question? So would the idea of your motion be that we would vote to adopt from vaccination through drinking water and block, right? And then the other two, we would like to hear more detail in the future. Okay, thanks.
Or do people want to vote on? I mean, I vote on the last two.
I mean, that's the question. I just want to make sure I understood the motion.
Two motions, two different motions. One to vote on the slate, the other to vote on the other two. Right?
I think the motion intent is to vote for the first group in block, yes or no,
Yep.
and then just vote for the last two individually. If they don't pass, then come back.
Okay, I think all right. Other discussion? Okay. I guess a good call to question would be, so let's ask for a vote about does the board approve adopting the metrics for 2-year vaccination rates, gonorrhea rates, adults who smoke cigarettes, opioid overdose deaths, active transportation, and drinking water standards proposed by the subcommittee? Please say aye.
Aye.
Any opposed? Okay, so those process measures are adopted. And then the next measure is about effective contraceptive use. Katrina.
So I don't mean to put but it's actually that bucket of access to clinical preventive services. So I'm with you, we can go through them one by one, but another way, back to Jen's suggestion, I was thinking even immunization rates are a type of clinical preventive service. So I guess my proposal would be, we can go through them one by one, but we could also say that the committee might want to consider what would be good measures of access to clinical preventive services that local health, process measures for local health. And it might be something in these two that get tweaked, or it might be something.
Is that a proposed amendment?
Yes. Although I'm ex officio, so I'm not sure I get to
okay.
propose anything. I get to opine, somebody else can propose.
I'll propose what Katrina said as an amendment that we vote on the access to clinical preventive services. I guess is.
Oh, yes, yeah, these are combined.
Yeah. So
Yes.
looking up there,
Okay.
it's that bucket
That's that bucket that we're concerned
Yeah.
about. Okay.
So I guess my motion would be that we that we request the subcommittee to come back to us with more details and recommendations about the access to clinical preventive service measures. Is there a second?
Second that.
Second, okay, thank you. Discussion. Okay, well, I guess all in favor of that motion, please say aye.
Aye.
I,
Thanks. Any opposed? All right, thanks, everyone.
Can I just offer something to clarify? Since we've already identified the health outcomes in access to clinical preventive services, I think the intention would be to identify a process measure that maps onto those. Otherwise, we need to go back and talk about them as outcomes. So I did want to clarify.
Yes, yes. Yeah, we haven't changed our previous outcome measures, but we'd like to hear more about process measures. All right, well, thanks everyone. That item took longer than we budgeted, but I really appreciate the feedback. I know that the subcommittee's been working hard on measures, and it's nice to actually have gone through both phases. Mike, thank you for walking us through that. So our next item is to hear about the Oregon Action Plan for Health. And so, Steph, we've left you not too much time for this, but I think from our earlier discussion, this is a topic that we may come back to in the future. So Steph, Harem will be talking about the plan for health, and so yeah, if you could set the stage for this. I think the way I see this is tell me if I'm wrong, this is the context for some of our recommendations that we might make, for example, about CCO contract items that relate to population health and public health.
Yeah, I'm happy to talk about that. So,
Press your talking.
oh, okay, great, thank you. So I'm Steph Jerem. I am a policy analyst in OHA's Division of Health Policy and Analytics, and I am one of the staff members for the Oregon Health Policy Board. Sorry for my cold, so hopefully that doesn't affect things too much. So I will give you some context and some background on the action plan and the work that's been done on the action plan, and also try and loop you in on the CCO 2.0 work that is going on as well. So I'll start just by framing up the action plan, and that should fold in nicely. So the original action plan for health was the first charge from the legislature to the Oregon Health Policy Board in 2009. Lillian could speak quite extensively to some of this work, so she might be someone who is useful to bring in. The board spent 12 months conducting listening sessions all across the state. They had hundreds of people weigh in with thoughts and ideas about where the state should go, really focusing on hearing from every type of person. So we had individuals and policymakers and business owners and members of the healthcare community, local government. And the results of all of those meetings was the 2010 Action Plan for Health, which aimed to address the issues of cost, quality, and access to healthcare. The plan included many items that didn't require legislative action, and instead really helped guide Oregon forward in achieving the vision of the triple aim. At the time of the Action Plan for Health, when it was published, we didn't know what CCOs were. We didn't know what they were going to look like. They mentioned a little bit about regional healthcare accountable organizations, and so that's really where we were at with that original Action Plan for Health. So similarly, some of the CCO 2.0 work at this point, we've done this refresh of the action plan that I'm going to explain in today's presentation. But we're going to use that as this overarching guide for where we want to go in Oregon over the next few years. And then underneath that, we have the opportunities within the CCOs to really use the CCOs as a driver for some of the things that we envision through the action plan. And I'm happy to speak more about that process of what that CCO, that next vision is going to look like. But it might make more sense if I go through this first, and then we can kind of talk to that. So next slide. So the reason that this occurred was that the board, towards the end of 2016, decided that we really should look back at where we've come, that we've gone through this initial implementation phase of the action plan and of health system transformation in Oregon, and we've learned a lot, and we really want to build on what has already happened. We know that there are best practices, we know that there are lessons learned. Let's take those and start to actually move the state forward and have a new baseline. So the goal of this new action plan was to move beyond this initial implementation that was laid out in the 2010 plan and to really push the boundaries on health system innovation and cross-sector collaboration especially. And so over the last year, the board has worked to update the action plan for health. It actually isn't on our website quite yet. It's been a little stalled in our publications process, but we should have a link for that within the next day, and we're happy to send that out to you when we have it. Next page. So in order to, the reason that this action plan is called the refreshed action plan is because the board felt like the original framework and the original work was really well organized and well done, and they just wanted to build on that and update it with new information. So we use that same framework. You see here this kind of pyramid. It's a little hard to see on the screen. But the Health Policy Board set the vision, which continues to be the triple aim, and it set the guiding principles and foundational strategies. So these are these long-term criteria to guide decision making and to set priorities, and a way of collapsing our work into overarching categories to incorporate all health improvement in Oregon. The plan then outlines key actions that OHA will be taking over the next 2 years in support of the vision and foundational strategies that were articulated by the board. And so it serves both as OHA's kind of operational plan in some ways, and then also as this visionary plan for the whole state of Oregon. So parts that we have control over, and then some parts that we don't. OHA staff organize and prioritize their work into focus areas underneath these foundational strategies that align with the vision and the foundational strategies. And that those actions is the true work of the action plan. So if we switch to this slide, this is kind of our, this is what we call the flow chart. These are across the top in orange are the foundational strategies set by the board, and again, these are very consistent with the original plan. We have pay for outcomes and value, shift focus upstream, improve health equity, increase access to healthcare, enhance care coordination, engage stakeholders and community partners, and measure progress. So these 7 areas are really the areas that the board sees Oregon needing to continue to drive work in the next few years through CCOs and then across the state. And then underneath that in the gray boxes are all of these focus areas. And so this is where OHA has organized their own work to align with these strategies. And we've also done quite a bit of work to ensure that there's alignment between the State Health Improvement Plan as well, and have done quite a bit to make sure that, that there's a partnership here and making sure that there's alignment. And so what you see here,
either we're locked in or somebody's locked in.
It's 5 o'clock, yeah, everything's shut down. What you see here was an attempt to categorize some of the work that the FAB is working on right now. So all of the red circles were examples that Karen and I could think through of areas that either there's current engagement of the FAB in these spaces or specific work that the FAB is overseeing or would be connected to. That being said, I'm sure it's not comprehensive, so I don't know if we want to take the time now or if we have the time, but it could be a good exercise maybe in the future as well to go through and really identify all the spaces that the FAB is interacting with this work, or that you want to do more work or see more insight into. So, next page. So this key actions list is where the true work of the action plan is, and it's incredibly dynamic, so this is why it's not going to be in the printed narrative. But we will have one, and this is, and again, the action plan is really dense, and I'm trying to have this be at the most high level as possible, but underneath those gray boxes, we then have the actual actions. So what is the agency doing in all of these areas? And this is constantly being updated. We're in a process right now of updating it. It will be shared publicly through the Health Policy Board. And this is just an example. So focus area 2.1, modernize public health system for the entire state. That's our focus area. And then underneath it, you can see the different areas and the ways in which we're tracking that. So the board really wants to know that in the next 2 years, how are we going to measure this? How are we going to say that we've actually achieved X% of the action plan, or we moved this far along in the action plan in these areas? So this is just to give you a highlight of what our tracking looks like internally. We'll be tracking the individual actions, which again will change over the next 2 years. This is a very dynamic list. So for example, as the Behavioral Health Collaborative meets and then they produce recommendations, we'll fold those recommendations into the plan, and then it will continue to be updated as we have new actions that are going forward. It will include a measurement target, baseline measures, and a timeline for when these things will be completed. We are also tracking what the public input process and the work group roles are for all of these. So you can see we have FAB listed here, but we have lots of other work groups and Health Policy Board work groups and other work groups that have an opportunity for public input and things like that. And then also for lack of a better term, the sphere of influence of some of these actions. So one of the areas that I think you'll be particularly interested in is we're asking across, we have over 100 actions, whether or not they are impacting population health. And so we'll be able to collect that and share that with you and say, here are all the different things in our agency that people believe are impacting population health. Okay, so the next steps are that we will be developing a dashboard and a report that will be going to the Health Policy Board at their January retreat. It will include the action, the status of the action, as well as selected achievements or barriers and opportunities for policy. And then there will also be some alignment with CCO 2.0. So I can jump into the CCO 2.0 just to give you a high level of what that's going to be. We're calling it CCO 2.0. That just is referring to the next round of procurement. So I think many of you have probably heard that a decision was made to delay the contracting of CCOs by 1 year. And so the goal of that is to take this year, and we've heard this from leadership and our new director, Alan, that we want to be really thoughtful about what this process looks like over the next year as we're entering into a new phase of procurement with CCOs, and if we're going to delay, that we're going to use that year to really understand what will make health system transformation in Oregon better, what will move us further along, how will we push the needle. And so right now there's a process going on internally to do some analysis on the first stage of CCOs to say, okay, what do we know? There have been evaluations, there have been lots of work done to understand what we asked CCOs to do and then where they've come, but let's get that all into one place and let's understand what we really know about how CCOs have done over the last 5-year cycle. And then the board will be looking at some of that at their retreat. I believe they'll be inviting the chairs of all of their committees to that retreat, so I think that'll be a really great opportunity for alignment. And then over the next year, so throughout all of 2018, there's going to be a very extensive public input process. Some of that might be done through committees, some of that might need to be done externally outside of committees, so there might need to be new opportunities for public input. And we don't really know what that's going to look like quite yet because we're still trying to understand what needs to go into that work over the next year. But it's going to be a really long process, and I think there will be lots of opportunities to weigh in, and we can work back and forth and collaborate and partner with the groups as they see fit. I think again, from what I have heard from our leadership, they really want this to be another statewide effort to understand what will make Oregon go a little bit further in the next round. So, with that, I did have some questions for all of you. Just wanted to know whether or not, based on what you've heard, and I'm happy to answer any questions you have as well, but for all of you, I was wondering whether or not there's anything in particular that you would be interested in seeing through the tracking, or any perspective that you thought should be brought to some of this action plan work to make sure that it's valuable to you as well. And then also how you would like to be updated on this work going forward. I mean, we can do regular presentations, or I could just share what the updates are. At this point, we think we'll be doing every 6 months presentations to the board, but I mean, whatever works for the FAB, we can work with. So with that.
So can I just ask a question about the dashboard? Is the dashboard something that we would be able to see, or how?
Yeah.
Oh, okay, so.
Yeah, it's going to be a public dashboard.
Okay.
We don't know what we're calling it yet. Dashboard report. I'm not quite sure what it will be, but something that will really detail, I mean, all of the information about these actions and what they're doing, and how far we've come, because we want this to be a transparent process about what the action plan looks like.
So so FAB members would be able to, any day now, be able to see the full action plan for health, and then when would the dashboard roughly be?
Yeah, that's a good question. So the list is currently being updated by subject matter experts within OHA. So that process is ongoing. We're looking at a completion in November. I'm not sure if we're going to have that list by the December board meeting. I kind of am doubting it, just because we want to make sure that it's consistent and aligned, and it's, you know, in the same voice and all that kind of thing. But we'll definitely have that with its status report by the January retreat. So that should be middle to end of January, and we'll be able to share that with you as soon as we have that.
Okay, thanks. Thanks.
And I can share a preliminary list. We did share at one of the board meetings a list of the actions, but it was from February. So at this point, we have a lot more updates and a lot more things to fold in, and some of that's already been completed and things like that. But I can share that with you.
I think that would be helpful. Just, I mean, you know, if we, and then to share with the board, because this was a really good overview presentation. Now it makes me want to go back and actually look at the plan and think about it in a bit more depth. But sorry, Lillian, you wanted to.
No, I was just going to, I just don't want people to get hung up on, is it dashboard, or is it report, or is it metrics, you know, I mean, but it is an attempt to take what evolved from the first action plan for health, and ultimately the metrics that the CCOs are being held to and actually being rewarded for or punished for, maybe more so in the future. And if you think of it, you could call it like a strategic plan, and when you do strategic plans for your own organizations, it always has actions that you're going to do to achieve that, and then you report on that. And then in the last 2 years, year and a half to 2 years, we've done a lot of management dashboards internally in public health, and with OHA, all over OHA, like really looking at what are the activities that are happening all the way down to the program level, the section level, the center level for us in public health, but that's true across all of OHA. And so to get those things aligned so we can make sure that the work that we're choosing to do is work that is understood to achieve the goal. So I think this is extremely exciting. I mean, we can look at it every month if we want to, you know, but this is really tying together that whole health. How do we all achieve health? So it's moving forward. A lot of work, and Steph, you have done an amazing job.
Thank you. I should know, thank you for that, but the action plan does not include kind of the business as usual operations pieces of OHA. So just as a note, we haven't tried to capture what the plan is for every step of some of our Medicaid transition work and things like that. So it's really more about what's innovative, what's new, what is transformational, things like that.
Okay.
I just wanted to comment, I appreciate the liaison roles and having Dr. Mainsberg on our committee. I know it's a lot of time commitment for him, but in the few meetings he's been with us, I certainly have felt a stronger connection to the policy board, so feedback for the board, I really appreciate that.
Great, thank you.
I'm sorry, yes, go ahead, please.
So I guess just a couple of comments. Maybe in your tracking or dashboard or whatever, distinguishing between health versus healthcare. I think we tend to get pulled into healthcare, as you can tell by our metrics. We tend to get pulled in that direction, so distinguishing. And then I was also going to say, the timeline of public health and health is much longer than the kind of timeline for hospital and CCO and healthcare system metrics. So also kind of taking that into account in terms of what you're watching and at what interval and what constitutes an improvement or a victory, because you're not going to see those quickly in public health.
Yeah, thanks for that. One of the efforts that we're doing internally right now is trying to capture how we're measuring some of these, and it's to that point. So in some ways we will have outcome measures, and in other areas we won't. And one of the examples we just had was talking about traditional health worker certification, and we should have a goal for that. We should know how many we want certified or recertified, or what the process should be for that. And that can be an achievement in itself without it being 100%. So it's really about the process and how far we want to go in some of these areas.
Oh, go ahead.
No, it's like, but if, to your point about the traditional healthcare, the whole original thing was to drive how we deliver care differently. So the medical home, the things that people get rewarded for. And I understand there's there is a longer horizon for achieving population health, but we've never been able to really articulate what are the components that achieve that across wherever you are. Are you sitting in an office? Are you funding something? Are you paying for something? Are you purchasing? What are you purchasing? What are those decisions? As well as what the public health system does, as well as small p public health, like your organization, like how are we really aligning those things to watch those things change overall in the state of Oregon. And I think you saw that one of the things that came up was that it's absolutely a requirement now that all of the dashboards and all the activities, even in the CCOs and in our purchasing, have to deal with equity. And that wasn't there, 5 years ago. We kind of believed in it, but we didn't know how to actually drive it with purchasing.
So I guess, Steph, your last question is, how would the FAB like to be updated about this? What would board members like to hear about this, and when? I think that's a great question.
I suggest early and often.
Well, one thing that we could do is in our next agenda planning meeting, talk a little bit more about how to update board members about, perhaps we could look at some of the specific areas, some of the ones that are circled and some items on the dashboard underneath that. So I think, like I said, you framed it up really well. So now I think we can actually look at some of the areas that are of interest to us and understand how they fit into the overall plan. Any questions from members on the phone for Steph? If there are any still on the phone. No.
This is Terry, I'm still here.
Oh, okay. Any questions?
I'm good.
Okay, thanks.
Okay. Great, well,
Alrighty. Thank you.
Yeah, thanks.
For joining us.
Thank you.
Maybe we can start with her next time.
I think we actually, the earlier part of the discussion got into areas that are going to that are covered by this plan, so. Great. So our last agenda item is to ask if there are any members of the public who would like to make comment. Has anyone signed up in person? Okay, so no members of the public have signed up in person to provide testimony from the board. Is anyone on the, anyone indicated online that they would like to? Okay, so I guess we don't have any public testimony today. Oh, yes, thank you, please do.
Yeah, so I just wanted to remind everybody that our next meeting is a little off our regular schedule. It's Friday, November 17th from 9 to noon, and we're meeting in Salem. So it'll be the day after this day next month.
Different day, different location.
Right.
Same us. Okay. With that, I would entertain a motion to adjourn.
So moved.
Second?
Second.
Okay. Those opposed may abstain.